All right, Dr. Castro-Marin, we're all set.
Okay, can you guys hear me okay?
Yes.
Yes, sir.
All right, thank you. Thank you everyone for joining. Today's Thursday, March 18th, and you are participating in the Protocols, Medications, and Devices Standing Committee. Some opening announcements. Attendees are advised that this public meeting is recorded and will be posted on the ADHS website. So anything said verbally, anything viewed by webcam, anything typed into the chat box will become part of the recording, and that will be publicly posted. Please mute when you are not speaking. If attending by phone only, you may need to press *6 to unmute yourself. Again, that's *6 to unmute yourself. Shelley and Julia will be monitoring the chat box for any questions you might have. And for everyone's benefit, please identify yourself before stating your remarks, as well as if you are making a motion or seconding a motion for my benefit, if you could throw your name in there as well. Thank you all for your participation and your patience. And we'll go ahead and we'll start with the agenda. Call to order. Roll call, please.
All right. Amber Rice. I see your name listed, but I don't hear you.
I'm here.
Okay. Thank you. Erin O'Connor.
Hi, I'm here.
Hello. Brian Smith.
Present.
Thank you. Chester Key. Franco Castro-Marin, I see you. The Garth Gamer is next.
Present.
Heather Miller. Jason Johnson.
Here.
Jason Payne.
Present.
Josh Gaither is absent. Matt Shaw.
Present.
Neil Gecko.
I'm here.
Paul Dabrowski.
I'm here too.
And Shari Brand.
Here.
I think 11. We do have quorum. Thank you.
Thank you very much. We'll go to attachment 3A, which is the attendance report. A friendly reminder that if you miss 2 consecutive meetings, the Bureau will contact you to ask you if you're still interested in serving on the committee. Does anyone have any questions on the attendance report? All right, then we'll move on. I'd like to personally welcome our newest member, Dr. Erin O'Connor, who's a toxicologist and works with Banner Phoenix. As Dr. O'Connor, thank you so much for joining the group and helping us from a toxicology perspective. It's a much needed resource.
I'm happy to be here. Thank you for including me, and I look forward to working with all of you.
And then item C is the vacancy report. And at this time, the PMD committee has no vacancies currently. All right, can we move on to the Bureau report, please?
Hi, good afternoon, Dr. Castro-Marin and committee members. This is Rachel Garcia with Arizona Department of Health Services. Apologies to anyone on the line who's had to listen to me share similar updates in this morning's meetings, but I'll share a few items. The Bureau continues with normal business operations. We also have some staffing updates. We are in the process of filling several vacancies and will begin interviews at the end of the month for the Services Section Chief position formerly held by Ben Fisher, and the position continues to be open to candidates online. We've recently welcomed some new staff members to the Bureau, including Compliance and Enforcement Manager Marley McCormick and Trauma Registrar Carissa Wilson starting next week. Julia Vinton has also been promoted to Health Program Manager, overseeing several of our grant programs in addition to the vacant EMS for Children position. The state jobs website currently features Bureau positions that are open and accepting applications. We have some rule updates. For Articles 9 through 11, the department continues to seek stakeholder feedback on the rulemaking process for ground ambulance rules. The Article 9 work group will continue to meet on a monthly basis to provide feedback on ground ambulance draft, and the department will seek additional stakeholder input for Articles 10 through 11. For Articles 7 through 8, air ambulance rules are being reviewed for final comments, and once a formal notice of proposed rulemaking is filed, there will be an additional 30-day review period for public comment. The remaining process before adoption is expected to be extended through mid to late 2021. For Article 5, scope of practice, based on the recommendations from the statutory committees to make sure that scope of practice is consistent with national standards, the Bureau is working with Administrative Council and Rules on an exception request for exempt rulemaking to update Table 5.1. We still expect this process to include a 30-day review period for public comment before adoption, and we'll keep the committees updated on progress related to scope of practice updates. We still have many emergency orders and waivers in effect during the COVID-19 response. I'll share a few items that have gone out via Gov delivery in the last couple months. Executive Order 2020-63 extends the Good Samaritan Order to provide healthcare workers and EMS providers acting in good faith with immunity protections through March 31st, 2021. Administrative Order 2020-15 provides limited EMS rule waivers, including flexibility on CON boundaries through March 31st, 2021. Emergency Measure 2020-05 authorizes all levels of EMCTs to administer COVID-19 and influenza vaccinations, as well as perform diagnostic viral testing with approval from an administrative medical director. We'll let Dr. Bradley and the team share some additional updates on training resources and protocols that will be available on the ADHS website. We're also doing some evaluation and looking for feedback from stakeholders on moving towards a digital EMCT certification process starting July 1. We will expect the governmental orders and waivers that are in effect now to be reevaluated, revised, and extended as appropriate at the end of this month or early April. That is all I have for now, pending any questions. Thank you very much.
Thank you, Ms. Garcia. Appreciate that update very much. Dr. Bradley, do you have a stab update for the blood product work group?
Yes, thank you. And I'll just quickly tag on to what Chief Garcia was saying in regards to some of the COVID guidelines. We do have the statewide COVID guidelines for EMS that were initially published in March and updated in July of 2020. We are in the process of starting to review and update those. As those do get updated, we will also update the associated training PowerPoint curriculum, and we anticipate hopefully having those live within the next few weeks. Once those are updated and finalized, we will definitely send out messaging via the Gov delivery system. So if you're not signed up for that, please let us know. We can help you get signed up so you can get that communication. In regards to the STAT blood product work group, we had a very productive initial meeting. Dr. Gaither was the chair of that subcommittee, and we had excellent participation from trauma centers, trauma physicians, pre-hospital providers, and EMS personnel, as well as EMS medical directors. We will have a follow-up meeting scheduled for later this month with the goal to hopefully have a finalized product that's going to be presented at the next STAB meeting, which would be in May. Any feedback from that group, we will also bring back to PMD as well. So good appreciation everyone who's participated in that. The next piece I just wanted to briefly mention, and then we will kind of hopefully get into a presentation from Dr. Glenn, but the Bureau is trying to advertise some of the naloxone leave behind programs that have been initiated in Arizona. As we look at a lot of the COVID data that we've seen from throughout the state and nationally, we have found that obviously COVID has affected a number of issues, but opioid overdoses and deaths have increased as well. And we are looking to try to increase utilization of where pre-hospital can affect change. And so one of these opportunities is the Naloxone Leave Behind program. We'll put the links in the chat box to where you can look to see there's a standing order for naloxone administration for EMTs that may not have medical direction, and also the statutes and everything that help support a Naloxone Leave Behind program. Excellent question that was brought up at the last meeting was, does ADHS have a method to supply naloxone? The answer is yes. In the chat, there will be a link, ADHS, to the Office of Injury Prevention. So not the Bureau of EMS, but Injury Prevention does have the ability to supply naloxone to EMS agencies. So each individual agency could apply for free naloxone to use for the naloxone Leave Behind program. And Dr. Glenn will hopefully be able to join us to give us a little bit more background on that in a few minutes. And that's all I have. Thank you.
Thank you, Dr. Bradley. Moving on to Julia for a share update.
Hello, everybody. Just a couple of updates for share. We are currently working on updating our webpage and documents related to cardiac receiving and referral centers, heart safe recognition, et cetera, as well as resources and training that are available on the website. Additionally, in the future, we plan to reach out to currently recognized cardiac receiving and referral centers so that we can gather updated information and make sure that our records are up to date. For EMS for Children, the next agenda item, we are currently in the process of conducting the EMS survey. Currently, we have 74 respondents, and that closes tomorrow. So thank you to everybody that's responded to that. We will additionally be participating in the National Pediatric Readiness Assessment, which is a national assessment, again, of hospitals that opens May 1st. So if you work in a hospital emergency department, expect to see some materials for that going out in the near future. For PACES, we had a Children with Special Healthcare Needs work group that worked on establishing a tracheostomy management training that was reviewed this morning at the Education Council and approved with amendments. So that should be posted on our website in the near future. That's all. Thanks.
Thank you, Julia. Moving on to Vatsal Chakani for an update on the data dashboard.
Good afternoon, everyone. So I have presented dashboards many times to all of you. So here I'm just going to give you the overview that we are keep on adding dashboards to our data visualization page. Apart from the annual report of trauma and EMS, you can see that we have a trauma overall dashboard. We have a EMS overall dashboard based on the annual report. We then develop few more dashboards on motor vehicle traffic injury, falls, and then race and ethnicity dashboards. For this year, we plan to add more dashboards to the data visualization page. If you guys have any idea, if you guys would like to see something, any performance major indicators, and once we are happy to basically work with you guys and develop some kind of a dashboard if that is useful to the community.
Thank you so much.
And if I can just chime in on some of the work that Vatsal has been doing with her team, they have done a ton of work, not just with our routine EMS and trauma reports, but also with a lot of COVID-specific data. She's presented at the last couple meetings some of our out-of-hospital cardiac arrest data and the effect of COVID with that, along with some of the opioid-related data. The next piece that we are looking at as well is evaluating how COVID has affected EMS refusals, specifically when we look at time-sensitive illness and injuries, such as chest pain, stroke symptoms, dizziness. So we will hopefully have that report to present at the next round of meetings. So a big thank you to Vatsal and her team for all the work that they've been doing.
Thank you, guys. Once again, great work, and I'm very much looking forward to having a look at that data and how COVID has affected our operations. The next item on the agenda is going to be Dr. Melody Glenn from Banner University Medical Center in Tucson. Dr. Glenn, are you on the call, and is this a good time?
Yes, it's a good time. I'm moving out to the hallway. Thanks, guys, for having me. Sorry I'm on shift. Can you hear me okay?
Yes, I can.
All right. So yeah, thanks for having me. I just wanted to do a quick overview of our naloxone distribution program that we've implemented in Santa Cruz County, just so other EMS agencies can see how easy it is and how our providers like it and maybe follow suit. So as you know, opioid overdoses have gone up a lot in the last year. One of the best treatments for that is Narcan. Ideally, we want bystanders and family members to have the Narcan so they can administer it while we're waiting for EMS to arrive. So we've developed in Santa Cruz County with our fire departments a protocol where they give out Narcan kits to anyone who's overdosed or anyone who's identified as being at risk of fatal overdose. And we're soon going to start distributing the naloxone from the fire stations as well, so people can actually come up and get the Narcan kits. It's pretty easy. I have a standing order that I made for our crews. It just says anyone at risk of overdose, teach them how to recognize an overdose, how to use the Narcan, and give them the kit. And we have a little sheet that's given along with the kit that explains how to use it. And there's also local resources on that kit as well. We also call a local peer recovery support specialist at Hope, who will come meet the patient in the field during normal business hours or come the next day. We have regulations that allow for this, and Dr. Bradley can speak further to that, but we do have Christ standing order, and there's also EMS specific regulations that allow this. I found that our EMS providers have really enjoyed this protocol. It changes the framework from responding to an overdose from one of kind of like, this is futile, they're just going to overdose again, it's kind of a pain, to, oh, this is a disease that we actually have the tools to treat. And so they've been very engaged and very positive about the experience. The community also seems to have appreciated it. We're putting out press releases soon. We've had pretty good compliance. About 70% of our overdoses get a Narcan kit, even those who we transport to the emergency department, because as we know, most emergency departments do not give out Narcan kits or start MAT treatment, both of which are the best treatments for opioid use disorder. The Narcan's easy to get. We get it from Arizona Department of Health Services, who's willing to give it out to agencies for Narcan distribution, as well as Norm Prevention Works. The ones from ADHS are intranasal, the ones from Norm Prevention Works are intramuscular.
Hey, Dr. Glenn, this is David Neres at the Bureau of EMS. With the fire department distributions, are they going to be doing any type of data collection or tracking on where it's being distributed?
Yes, and actually that's a great point that Dr. Bradley and I had talked about before. Yes, so some other agencies who have been doing this ahead of us in North Carolina found that a large percentage of their patients who they give out Narcan to actually aren't patients. They're just people who have found out about the Narcan distribution. So there's no EPCRs, just people who are going up to the fire trucks and asking for Narcan, for example. So we actually have like a little paper form that they can fill out, or they can do it electronically on their phone with a QR code, so they can document for those people that they give Narcan to who are not actually patients.
And Melody, I think I saw Garth Gamer had his hand up as well for a question.
Oh, hi, Dr. Glenn. This is Garth Gamer. You mentioned a training component that your field personnel were using to educate both patient and loved ones. Can you go into the nuts and bolts of that a little bit, and specifically how long time requirement for the people on scene, and you know, that's ordinarily kind of a difficult sell to get people to stay on scene and go through such a thing. Can you explain?
That's a great point, because we are asking to do more than they would normally do, especially if they're being transported to the emergency department. But really, studies have shown that the training doesn't need to be very significant. In fact, there's also studies that show that people who get no training on how to use Narcan versus those who get training both have the same rates of appropriate Narcan administration. So you could make the argument that no training is actually okay. But I just have them go over the mnemonic blue, so basically just recognizing an overdose, and then with the spray particularly, it's very easy. So I don't expect it to increase scene times very much.
And Melody, if I can speak to that. So Melody had put together an excellent kind of trifold flyer for Santa Cruz County with kind of helping people identify signs of an overdose, and had pictures of how to administer the intranasal naloxone as well as local resources. And I happily stole from hers and adapted that kind of to one of the areas here in Maricopa County as well, and implemented that. So it is something that you could actually create a pamphlet that could go out with the naloxone that has local resources for people to get further follow-up care, along with how to administer the naloxone, so that the actual training on scene would be pretty minimal that would be necessary.
Thank you, Dr. Bradley. Yeah, you can even just have them go over the pamphlet, and that could be the training.
Thank you.
I see Dr. O'Connor also has raised her hand as well.
Yeah, Dr. Glenn, this is Erin O'Connor. I'm a medical toxicologist. And first of all, I just want to say thank you. This program, I think, is going to be very, very helpful to a significant population of patients. So thank you for all your work on this. One question was, do we have instructions in multiple languages? Was the initial question. And then the second part is probably beyond, is to the larger group, and maybe just for some context for me. You mentioned that in our emergency departments, we're not handing out naloxone and initiating MAT, and I'm just wondering, is there actions in place to try to correct that, I guess, going forward?
So the first part of your question, we should have this in Spanish. You're absolutely right. And we don't at this time. So that's something that should be addressed. And secondly, yes, Jacqueline Kurth at ADHS has spearheaded a panel about getting ED naloxone distribution going across the state. It's in a few hospitals in Arizona, but by far the minority. So there are steps being taken to improve that. There are some small steps at individual hospitals about MAT initiation at EDs, but again, that's pretty small scale at this time, as far as I know.
Thank you.
Anything else in closing, Dr. Glenn?
If your agencies are interested, I'd be happy to share our resources, including our standing order, including the training presentation I made. I made like a 10-minute video for crews to watch before it goes live. So if you want any of those resources, I'm very happy to share.
And just to tag onto that, the Education Committee in the last meeting did approve forming a work group to create statewide education, and I volunteered Dr. Glenn for that.
Awesome, thank you.
Dr. Bradley, a follow-up question. What does DHS have the bandwidth to support an influx of interested agencies in terms of supplying them with the appropriate materials?
Materials meaning training or the naloxone itself?
The naloxone itself.
So that is through the Office of Injury Prevention. Jackie Kurth, who is the office chief, has said that they do have ample supply of naloxone. She does not feel like that's going to be a barrier. She's even said to the meeting that Melody was just mentioning in regards to the actual EDs who are looking to administer this, that they have funding to help support that. So it sounds like there is a decent amount of funding to help support intranasal naloxone, both for EMS agencies as well as for emergency departments.
And do you have any details in terms of how that distribution actually works, the supply chain from an agency, especially a rural agency, how they acquire the materials?
So I see Dr. Glenn shaking her head. I did put in the chat box the link to the ADHS opioid site, and that has the actual link to the naloxone request. So order naloxone for your agency is on, there's a tab there in a form. And then Dr. Glenn, I know you've utilized that, so maybe you can speak to that a little bit more as well.
Yeah, that's exactly it. Thank you for putting that in the chat. It's pretty easy. It's a small form and they'll sign off on it. And Storm Prevention Works has a similar form, and they're happy to send you naloxone as well.
Is it just shipped?
Yes, it is.
Okay, gotcha. All right, well, thank you. This sounds like an amazing program, and I personally wish you success in Santa Cruz County, and it sounds like you guys have really done the hard work to scale this up for the rest of us, and that makes everyone else's job much easier. And no doubt many Arizona citizens will benefit from this great public safety and public health measure. So thank you all for your ongoing work and dedication.
Thank you. Thanks for having me today.
Dr. Bradley, any other comments?
I see Dr. O'Connor had her hand up for another comment or question.
Yes, just a question for, again, my understanding is the Arizona Board of Pharmacy kind of been looped into this so that they are fully supportive of dispensing and all the different agencies that would be, technically dispensing a medication. Are they fully supportive, and have they been part of these conversations?
Not as far as EMS is concerned, but I have for emergency departments. And I want to say a key point of distinction is that it's not dispensing, it's distributing. And because we're not going through a pharmacy, we don't have to apply for pharmacy regs, or you don't have to follow the pharmacy regs since it's not actually going through a pharmacist or a pharmacy. Because of Dr. Carter Price standing order, Narcan can be distributed very easily. You know, organizations like Storm Prevention Works, which are lay people, are giving out naloxone. And so the board has had no problem with our ED distribution, and so I haven't even gone to them about EMS, but I didn't anticipate it to be a problem.
Okay. Yeah, great. Just anything we can do to make sure there's clarity and no barriers, right? The more we can get out there and get in the hands of citizens, the better. So
far, pharmacy has been really supportive. My main point there has been Doug Scarvla, and he's been really helpful and responsive. And Dr. Bradley, maybe you can mention or speak to some of the EMS regs that allow this as well.
Correct. So actually in the initial Arizona revised statute that I think was published in 2016 or 17, it actually specifically mentioned naloxone leave behind. So whenever that was initially written, they were actually very forward thinking and had put that into, so that was what required EMS to report on opioid overdoses as well as naloxone administration. In there was also verbiage specifically that allowed for EMS agencies to perform naloxone leave behind. So that has been in there. We did notice when we were preparing for this that the some of those documents, they're not as easily found on the Bureau of EMS's website, so we will work on getting that linked. Right now, they're under the main ADHS opioid website, but we try to have anything EMS related on our page as well. So we will work on getting that linked. And then we also noted that we do need to update some of the names in there since we do not have Chief Garcia's name on a couple of the forms, and one of them does need to be redated, and the one order for me has expired. So we will get those updated as well.
Thank you, everyone. What a great example of a collaborative effort spearheaded by Dr. Glenn, who hopefully this is just the beginning of her amazing contributions after returning to Arizona from fellowship in California. So again, Dr. Glenn, thank you so much. And I'm very much looking forward to your ongoing work in this and other areas.
Thank you.
Moving on to discussion and action items. If we can start with the approval of the PMD minutes from November 19th, 2020.
So moved, Brian.
All right, Brian, with the motion, can I get a second?
Second, Jason.
Jason with the second, thank you so much. Any changes or discussion? If there's no further discussion, I'll call for the vote. All those in favor of approving the minutes as they stand, say aye.
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 Any opposed? Anyone abstaining? All right, and the approval of the minutes motion passes. Thank you very much. The next item is discussion of the 2021 update to the NASEMSO EMS model EMS guidelines.
Thank you. I can speak to that. So it is pretty exciting. This, at the state, this committee spent probably hundreds of hours combined working on the Arizona TTTGs, which were based on the last version of the NASEMSO model EMS guidelines. Those were put forward as getting rewritten. They had asked for volunteers from the different states last fall, and they didn't hear much until January when they said, okay, the process is starting and we're looking to update these. The timetable is pretty fast for this. So these are actually all revisions have to be submitted by July to NASEMSO. There are stakeholders from ACS, from NHTSA, NAEMSP, NAEMT, so kind of all throughout the EMS and pre-hospital community. And so we are looking, they anticipate that the final updates will go live hopefully by January of 2022. And that's including, I think, a 60-day public comment timeframe in the fall. So based on the format going forward, I anticipate that these will be updated and ready to go for us to start reviewing and kind of working on our updates here in Arizona with the TTTGs. I wanted to give that update just due to the fact that it's kind of exciting. This is, I think, 4 years since the last version. And really, I think in Arizona has helped us to create more kind of evidence-based EMS guidelines. So I wanted to bring that information to this committee as you guys really were the workhorses of putting the state TTTGs together. Any questions that I can answer about that or that process? Anyone have PTSD from when we worked in this the last time? It was a ton of work.
I'm already penciling my shift requests for January 2022.
Yes, it's a big lift. Hopefully, a lot of what we struggled with the last time was really some formatting and kind of coming up with a good format and process. And I think this time around, I will luckily have the inside track to be able to see kind of the track changes version, which I think as we look to implement this at the statewide level and update things, that should hopefully make that transition a little bit more smooth.
Thank you for the update. My only suggestion is that we try to make sure that we have, as the time approaches, make sure that we have the human resources necessary for the technology piece, especially our PowerPoint wizards to help with the actual hands-on, because a lot of that is the rate limiting step, is just getting folks together in a room and getting the actual edits done and all the typos corrected, et cetera.
Yes, so we've got some time. We're looking about 9 months probably before we'll start, but definitely we can figure out kind of the best process moving forward so that we can have this. So I'm watching the way the national committee is doing it, getting some tips of how they do that in the national level to hopefully bring forward as well.
Great. Thank you for representing us at that in that setting. So that is not an action item at this point, just a discussion point, followed by point C, another discussion point, looking at alternative options for Arizona-specific ACLS/CPR training with the University of Arizona.
Yes, so I'm excited, and I wanted to introduce Dr. Rice to just give a brief overview of the program that she has been kind of the spearhead in developing, and really an exciting point when we look at all of the cardiac arrest work that we've done in Arizona going back 12 years with the implementation of first what was termed CCR and then transition to MICR. A lot of this joint public health initiative of really figuring out how do we do resuscitation, or how can we do resuscitation better and the pre-hospital setting has made Arizona a leader in cardiac resuscitation. And so really excited to see some of the work that Dr. Rice has put in terms of updating a curriculum and guide that really is more based on kind of pre-hospital management of cardiac arrest versus a lot of the inpatient setting that some of the other programs are based on. So I'm going to turn it over to Dr. Rice just so she can give us a brief overview on her program and its development.
Thank you, Dr. Bradley. So I just wanted to give a brief overview of what we've done here down in Southern Arizona. The initial development of this program came from an EMS agency that I'm very lucky to be able to work with. They've been really involved in the sort of MICR and high performance CPR concept since the early days when Ben Barbaro had developed some of this programming through the DHS and the SHARE program. So initially, there was a desire to move away from specifically American Heart Association curriculum, which is what they've typically been taking, mainly due to conflicts with their training. So that American Heart Association curriculum does significantly conflict with our current protocols, as well as a lot of the education that we provide for the pre-hospital providers. It's also a very costly program for the organization to sustain training on a every 2-year basis for this. And then obviously with COVID, we had more difficulty in, there's more difficulty finding courses and trying to go out and find a training center and then, go out to actually get your skills testing done. It was very time consuming. So we developed basically a BLS and an ACLS course that's, consistent with national guidelines. It uses the same CPR science, but really focuses the curriculum and the training on pre-hospital management of out-of-hospital cardiac arrest. So I've been involved with Ben Barbaro and a bunch of folks around the state in his high-performance CPR university before he had left. It's a very great 2-day workshop. Unfortunately, it wasn't accessible to our providers as a training curriculum. So I was able to take a lot of those concepts and a lot of the training we do in our department and translate that into a curriculum that sort of mirrors the way the AHA does it. So there's an online didactic curriculum that the providers would take for either the BLS and then also the ACLS curriculum. And then we have a Train the Trainer program that teaches specifically the skills for BLS management, ACLS management, and then the high performance CPR pieces, or like sort of pit crew CPR. And then we turn this into a program because we wanted to make it accessible to other agencies as well. So we went through the process at the University of Arizona to create a licensing agreement so that we could train other agencies to do this. So right now, the way that the program is set up is that you would be able to take a train the trainer course with your agency, and then those trainers would be available to do the skills testing portion of the curriculum. So you don't have to go out and find another location. You don't have to have a nurse do your skills checkoffs for your ACLS providers. You actually be able to do all of this in-house. And so it's created a lot of flexibility for our agency. We actually build our skills testing into our quarterly training. And so the quarterly training of the skills testing gets performed, and then every 2 years, we actually do it every 1 year, but for the program, it's required every 2 years to do the didactic curriculum, similar to how the American Heart Association would do it. I think that's about it. The train the trainer session really focuses on how to teach performance CPR and skills in a sort of more condensed fashion. So a one-day course versus a 2-day workshop to learn how to sort of teach some of these skills and do the skills checkoffs. So if anyone has any questions, happy to take any questions or other comments.
Thank you, Dr. Rice. This is Franco. I just have a couple follow-up questions. Does your curriculum take a stance on automatic compression devices?
We have training built into this, the training and the skills portion on how to successfully put them on. We don't take a stance on whether or not to use them. It's not required to have them. Our agency does use them when we do transport cardiac arrest, but it really mostly goes into how to effectively use them, how to effectively put them on, and how you do those transitions. So it's very specific in the skill. It doesn't really go too much into, whether or not to use them.
And so if I understand correctly, this is basically sort of a homegrown process to mirror that of a national product, which is the AHA ACLS credentialing training and credentialing process, using the best practices in science that we've been developing over the last 15 or so years. Is that a fair description?
Yeah.
Okay. And so where do we stand then on this ongoing debate in terms of distinguishing respiratory etiology versus cardiac etiology, and how you enter the pre-hospital management and trying to simplify, what essentially are two parallel pathways depending on the etiology of the cardiac arrest in adults?
So, essentially our training philosophy is to really simplify out-of-hospital cardiac arrest management. So we do basically treat all cardiac arrest patients the same in this program. So everyone starts out getting high-performance CPR, good quality chest compressions, and those individuals who have a obvious cardiac etiology, short downtime, witness cardiac arrest, the training includes that first few minutes of passive oxygenation and the explanation for why that's important. And then for individuals who have an obvious respiratory cause, asphyxial arrest, choking, drownings, they get upfront positive pressure ventilation. So that's really the only difference in management in adults for out-of-hospital cardiac arrest.
All right. So then, so again, for the purposes of thinking in the context of how protocols will continue to be written for larger Arizona regions and the state in general, it sounds like we will continue to have that slightly dichotomized branch point in terms of how a patient will either get or not get early ventilations. Is that right?
Mm-hmm. Yeah.
Okay.
Obviously any agency can set their protocols the way they wish. I can't dictate that, obviously. We just describe what we consider to be best practices.
No, that sounds great. And just a really an awesome endeavor to bring that in-house and create an alternative pathway based on some pretty amazing science that we luckily have developed here within the state of Arizona. It's been an amazing legacy over the last 10 to 15 years, and this is just a testament to that. So again, thank you and your team for all your hard work on this and putting together. This does not sound like it came easy, and I'm sure it took a lot of man hours for your folks to move through with the licensing agreements and what sounds like a fantastic product. we're looking forward to hearing more on that. Does anybody else have any questions on the matter?
Hi, it's Brian.
Hi, Brian.
I would just like to confirm that that is going to result in a certification.
Yeah, so it does have a card that goes along with it. When you do the online didactic portion, that completion gets tracked, and then the agency, once they complete the skills checkoffs, that will also get sent back through our program, and it all gets tracked, and the individual gets like a CPR card or an ACLS card that is like a completion certificate for them.
Okay, I just wanted to make sure, because for National Registry, you don't even have to have certification anymore. You just have to have hours, but I'm not nationally registered, so I have to have a certification that I attest to all the time.
Yeah, exactly.
Hey, Amber, it's Shari Brand. Real quick, cost-wise, how does that part work?
Yeah, so I mean, the goal of this program obviously was to make this more affordable for EMS agencies, for sure. So there is a licensing fee for the agency, or basically to become a training center. So it helps us, obviously keep internal costs so that we can keep running the program. But the trainer session, so the trainer session is a per trainer charge for the EMS agency, and then they can sign off as many people as they want for the program. And then there's a per card charge, which is much more minimal than the AHA charges. So right now it's set at $3 a BLS and $50 an ACLS card. And then you can, once you have the trainers set up, you can, basically do as many as your agency wants.
Any other follow-up questions? Dr. Bradley, any final comments on the matter?
No, thank you for presenting this. I think it's exciting to try to continue a lot of the work that Dr. Barbaro had put into place and really made Arizona such a leader in cardiac resuscitation. And, as we're hopefully getting our head above water with COVID, we can kind of take on some more of these projects, like looking at cardiac arrest resuscitation and some of the opioid-related emergencies in the pre-hospital setting. So thank you very much for being willing to present today.
Yeah, thank you very much. Anyone can email me anytime if they have more questions, or happy to chat by phone anytime.
Thank
Do you want to put your email in the chat box, maybe for anyone who wants to contact you? Thank you.
Yep.
Thank you again, Dr. Rice, for your time and a great presentation on a fantastic initiative. Item 7, if I remember my Roman numerals correctly, any agenda items to be considered for the next meeting?
Franco, this is Gail. I had one item that was brought forward to me when we did the updated drug profiles. We had focused initially on trying to just get primarily the table 1 drug profiles. There was a request from a paramedic who actually wants to take on starting the project of the toxmedic drug profiles. And so they are willing to do that. So I may put that on the agenda if this group is interested, and then obviously use Dr. O'Connor's expertise with that as well.
Great. Anything else from the group or from the public on any agenda items for next meeting? Hearing no comment, we'll move on to call to the public. All right, and hearing no comment on the matter, we're moving to item 9. I'll summarize upcoming events. Let's see, there's a free 4-hour virtual traffic incident management training course with CE available. Dates are March 31st, May 5th, August 12th, and November 9th. The agenda has that information with appropriate links. April 20 through 22, the 2021 National Rural EMS and Care Conference, which will be held virtually this year, and that is also available on the agenda. June 15th and 16th, is that AZ Share Annual Rural Health Conference in Flagstaff. Shelley, do you know what organization that is? I'm sorry, I don't recognize the acronym.
For June 15th?
Yeah, is that the Rural Health?
Yeah, the Centers for Rural Health.
Got it. And that's in Flagstaff. Yeah, I see. The UA Center for Rural Health. Thank you. July 13th and 14th, the statewide child abuse prevention conference will be held virtually. July 14th through 16th, there's the Western Pediatric Trauma Conference in Huntington Beach, California. And October 7th and 8th, the Southwest Trauma and Acute Care Symposium, which will be held virtually. The upcoming events calendar is also available online through the Arizona DHS website. And then there's also the training programs page for other upcoming CE opportunities. The next PMD meeting is on schedule for July 15th, 2021 at 1200 hours, location to be determined. And unless anyone has any other, it looks like Shelley has a agenda item, a conference edition. June 9th is the Ems Odyssey conference, and I'm sure we will get that added to the online calendar as well. That's a June 9th Ems Odyssey conference. And without any other comments, we will go ahead and adjourn at 12:46. Thank you, everyone, for your attendance.
Thank you, everyone.
Thank you.
Thank you.
Thanks all.
Thanks.
Thanks. Good meeting.